Can you hear me?
Yes, I can hear you.
Oh. Wait, okay, now can you hear me now?
Yeah.
Okay, I can hear you too.
Okay, good. And then did you have like a PowerPoint that you want to share or?
Yes, I do. How do I share it? What do I do?
Okay, so, and I've made you the host.
Okay.
So, so I did make you I actually made you the host, not me. So, but that just means when we're ready, you have to push the record button on the bottom. So on the bottom in the middle of your screen, there should be like a green file that says share.
Oh, okay.
And if you click on that, it then will pop up like all of your different screens. So like if you have your PowerPoint open, it would then should pop up like the PowerPoint.
Okay, I have to go.
And then you just select it to where it's highlighted blue, and then you would do share.
Does that look right? Can you see it?
It does look right. Yep.
So then, oh no. Okay, so I can pause share, stop share. I don't see record anymore though. Or is it just? So can you see on here then if it's like, is it recording right now?
It says recording.
Oh, so then.
Up in like on my screen in the very up like left corner, it's got a little button that says recording.
I guess it has like a little blinking light. I assume that means it's recording. I just have like stop share, pause share now.
Had you hit the record button before?
I don't think so.
So what about if we just stop share?
So once I do that, then I see like pause or stop recording as an option, like because my screen changes.
Oh, okay, so then yeah, so it is recording.
When I start doing this share screen, then that will start recording, I assume, right?
Well, it looks like it's recording right now.
Oh, okay.
Still says like my upper corner still says recording. So like if you press stop recording
and share screen.
Now it says recording.
So then
there, now it's recording and you're sharing.
There. Okay.
So, welcome everybody today to North Dakota Brain Injury Network's Webinar Wednesday. We are today going to be listening from Diana Palm, who is a physical therapist with Sanford Neuro. And she is going to do an overview of physical therapy for us today. So thank you very much. And thank you, Diana.
Thank you, Rebecca. So like she said, my name is Diana Palm. I'm a physical therapist with Sanford in Fargo, North Dakota. I work primarily with adults in the outpatient setting who have a type of neurologic impairment. I'm a board certified specialist in neurologic physical therapy, and I'm also a brain injury specialist. North Dakota Brain Injury Network asked me to speak today about what physical therapy can do following a brain injury. So let's get started. So just to start off, let's go to the basics. What is physical therapy? So in general, PT is care that aims to ease pain, help you move and function and live better. PTs practice in many different areas. So I'm a neurospecialist and I work with people who have brain injuries, spinal cord injuries, Parkinson's, things like that. But there are many different other specialty areas within PT, such as pediatrics, geriatrics, orthopedics, sports, women's health. There's also various settings that PTs work in, all the way from acute care to outpatient clinics, nursing homes, schools, patient homes, etc. We see people from all ages for anything that might be affecting their mobility, which is just in general how you move in your environment. So who are physical therapists? By definition, PTs are movement experts. We work to improve the quality of life through exercise, hands-on care, and education. We will make a PT diagnosis based off of various testing, and we would do in your first PT visit, and then we make a personalized plan to address whatever it might be that brought you to see us in the first place. Pain, injury, we might try to be preventing an injury or treating a chronic disease. So PTs are just one part of the brain injury team. So when treating somebody who has a brain injury, it takes a village. It's rare that we see somebody who has a brain injury who just has difficulty with one aspect of their life. They need help with taking care of themselves. They need help moving around. They need help with speech and thinking. And so you might be working with any or all of the people on this list, and there might be other people who aren't on this list that you could be working with too. So just again, we're part of the team. We're not the only people that you're going to see. I just wanted to list out some different types of brain injuries. Some important things to note that there is a pretty wide range of things that would be considered a brain injury. So one thing, a concussion is, sometimes people don't really think of that as a brain injury, but it is a brain injury and we need to treat it as such. It's an area that I think we could do better at as far as diagnosing. Concussions are hard to diagnose and probably underdiagnosed because there isn't really a great way to diagnose it with one just test or image. So I think that's an area we can improve on. I do think it's moving in a positive direction with especially young athletes getting baseline testing and better assessments before they get back into playing sports. And then another thing to note on here is that strokes are now included in the definition of brain injury for the state of North Dakota. And so that opens up some new resources for us. Okay, so you've had a brain injury and you're gonna go to physical therapy for your first visit, and that's gonna be your evaluation. So a PT evaluation is an assessment of your mobility. All of the things that are listed on here can affect how we move. We will look at what we consider to be normal for a healthy person, what our patient's normal was before their injury, and then what are we seeing with them right now today. So we'll look at your range of motion. Are your joints or your muscles too light or too loose? We'll look at your strength. Can you move your body or your limbs against gravity? Can you push against resistance? We'll look at your sensation. Can you feel pain? Can you feel light touch? Can you feel hot or cold? Can you tell where your foot is or what it's doing without having to see it? We'll look at your tone. Are your muscles contracting how they should? Are they contracting when they shouldn't be? That would be called increased tone, spasticity, or hypertonicity. Sometimes increased tone can be a problem. Sometimes it can be useful. If somebody has weak legs, but they've got increased tone, they might be able to kick that tone in to help them lift their legs into bed. And so we just need to figure out what's going on and if it's helpful or not. We'll look at your coordination. Are you able to move your body with the speed and accuracy you need to complete a task? We might look at your vestibular system. So this is a system in your body. It's located in your inner ear, helps you with keeping your body upright and maintaining your balance. If your vestibular system isn't working, You might have issues with dizziness or balance, and that can be a big problem. We'll talk about your pain. Is it interfering with your movement? Do you have pain? Is there anything that we can do about it? We might look at your cognition. As a PT, we typically aren't the one on the team doing formal testing of your cognition, but we still need to get an idea of how our patients can understand and follow our directions. Do they have good safety awareness? Are they impulsive? And we'll get an idea of that at the evaluation. And we'll also talk to our speech therapists and occupational therapists about that as well. We'll look at your balance. Are you able to sit and stand unsupported? Are you able to stand on uneven or unstable surfaces? We'll evaluate your balance, and we'll also evaluate why your balance might be impaired. It might be related to realizing that you're losing your balance. Can you feel that you're losing your balance? Or it might be related to how well you're able to correct when you have a loss of balance. Gait is kind of our fancy word for walking. Can you walk? Do you need help? Do you need a brace or a walker? Is your walking efficient? Is it too tiring and it wears you out so you can't walk very far? We'll look at transfers. This is changing positions or moving from one surface to another. How well do you stand up? How well do you move around in bed? How can you get in and out of your bed? We'll also talk about other things that would relate to your mobility. What was your mobility like before your injury? Did you need a cane because you had knee pain? Were you a big golfer? Do you live alone? Do you have a husband? Do you have kids? Do you have a dog? Did you work or go to school? And are you planning on going back to these things? And then I think one of the biggest things that we'll talk about during your evaluation is, what are your goals? What's important to you? What do you want to get out of physical therapy? What do you want to be able to do as far as mobility is concerned? So I put this list on here. It's some of the standardized tests that you might be asked to do during a PT evaluation. Or as a PT, it's important for us to pick the right types of tests to do with somebody. We need to pick tests that are going to be challenging, but not too challenging. We want you to take a test that's going to accurately reflect how well you're doing with your balance or your walking or your mobility, because this is going to give us an idea of what we need to work on during our treatment sessions. The parentheses behind some of those tests are the high score. So you can see, for example, if you see the mini best test is out of a 28, if you score a 27, that's really good. You see the Berg balance scale is out of 56. If you score a 27 on that, it's not going to be as good of a score and show that you're at a high risk of falling. So if you have one of these tests and you don't understand what the score means, or your PT doesn't explain it to you, just ask questions, because it's important for you to understand what those scores mean and how we're going to use them to work on your treatment. So the nice thing about these tests is most of them have a lot of data that is going to tell us, what's normal for someone your age, and then what score is going to put you at a higher risk of falling and things like that. Okay, so we've had our evaluation and your PT is starting to work on your plan of care. And so we get to talk about what our treatment is going to be next. So everyone's treatment is going to be different depending on what we find in their evaluation, what are your needs and what are your goals. In general, some of the big areas that we work on are strengthening, stretching, transfers, balance, and gait. So strengthening is simple. It's just improving your strength. We're loading your muscles. We're trying to make them work harder. And then the idea is that they're going to respond by working better. So we might use handheld weights or ankle weights. We might use resistance bands or body weights. So that would be like doing squats or lunges and things like that. And then we also could use different weight machines if those are available to us. Stretching is something that we also might be addressing. If your range of motion, how far your joints can move, isn't adequate for what we need to do, it's going to make that task a lot harder. So let's say your ankles are tight and you can't stand on a flat foot. Well, that's going to make standing up straight and walking with good upright posture significantly harder. So we might need to loosen that up before walking is going to get any easier. So we might be doing the stretching ourselves. We might be teaching your caregivers or you how to stretch yourself. We also might be looking at getting splints or braces like that. It's called a Prefo boot in the middle of the slide. That's going to give you a long, gentle stretch over time, or it also could just prevent your ankles from getting tight if you're spending a lot more time in bed. I don't think we're probably going to get to that body twisting pretzel position that that lady has, but maybe that's something to work towards. All right, transfers. So like I said, transfers are changing position or moving from one surface to another. So we want this to be safe and effective. Do we need to practice getting in and out of bed? Do we need to have a caregiver learn how to teach you to get in and out of bed? Do we need to work on getting up from a chair so that walking across the room is easier? Do we need to work on getting up and down from the floor so you can play with your kids or play with your dog or do something like that? And balance, I think this is fun. We need to make sure that you're steady, moving efficiently, and not falling. So we might challenge your balance in sitting, standing. We might change your surface on incline or foam. Basically, whatever is making you unsteady, we're going to be doing more of that because we need you to work on it. Balance is a complex system that we have. So when we're doing that assessment, that initial evaluation, we need to figure out why you're having troubles. For a healthy person, we get information from 3 different body systems. Our brain processes all that information, and then your body reacts and catches your balance without you really having to think about it. So those systems would be your vision, your sensation, and then that vestibular system and your inner ear. If one of those systems isn't working well, those other 3 systems need to kind of step it up to help balance things out. So what we can do in PT is kind of retrain your body to use the systems that are working well more effectively to make you feel more steady. All right. So gait training, I think this is one of the big things that we think about when we think about PT. Most people who come to see us when we talk about goals, they say, well, I want to walk again. Some people, walking means I just want to be able to get up and get from point A from point B. And for some people, walking is getting back to how they were walking before their injury. Either way, PTs are going to be the ones that are going to work on getting you up on your feet and moving. So we might use different things to make that safer and easier depending on our patients. So this picture over here on the side here is an example of a harness system that we sometimes use in clinic that we can put the harness on and then suspend them from above. It allows for you can hold onto the machine, you can hold onto the treadmill, you can hold onto a walker. That particular one can be used over a treadmill or it can be used over ground. There are also different systems that are like a ceiling track that allows you for wearing that harness and being safe, but a little bit more freedom of movement. And this is, again, it's just one example of a device that we might use to make walking easier. We have different options that we can do. We've seen maybe parallel bars or different devices that help with walking. Then when we first get started, and our goal is to eventually get you to the point where maybe you just need a more basic device or nothing at all in the long run. Okay, so I'm going to go through just some different types and styles of equipment that we might recommend in PT. This is by no means a complete list, and it's just kind of an overview. There's a lot of different options of these things. And so that would be something that you'd work with your PT on figuring out what's going to work best for you. So these are different mobility devices. We can go anywhere from something simple like a cane into different styles of walkers, crutches. Sometimes you'll need more than one type of device. Maybe you need a walker for shorter distances, but you also need a wheelchair for longer distances. But we can work on figuring out what's going to work best to allow you to be mobile and safe. These are different styles of braces. So these are just lower limb braces. Typically in PT, we work on the lower limb bracing. If you need anything for the upper extremities, you're going to talk to your occupational therapist about that. If you have ankle weakness or tightness or spasticity, you might need a type of ankle foot orthosis or AFO. So the first one on the left is a pretty simple off-the-shelf version. It's made of carbon fiber. It's light and it's going to hold your foot in position. The second one is more of a custom AFO that's molded to your leg and made specifically for you. That you can do a lot of more different things as far as keeping support and control of the lower leg. The third picture is actually a knee ankle foot orthosis. So that goes above the knee up to the thigh. And that would be used if you need more control of the knee. And the last picture is a version of a foot up assist device that is just going to kind of hold those toes up if you're weak in the ankle. It doesn't really give you a lot of support otherwise. So I think it's important to find the least restricting type of brace. And if you don't need the brace, then we shouldn't wear it. But our goal is to get you up and moving safely. And sometimes a brace is really the best way to do that. A good brace that's well made can make a really big difference in your mobility, can allow for easier and safer walking. And those custom braces can really do a lot for us if we need to manage tone or control that lower leg. We work with orthotists and they help us to get the right style of brace and then make those custom braces for you. So next is wheelchairs. Wheelchairs are something that we might recommend in PT based off of what you need for mobility. If you can't walk at all, a wheelchair is a good option. If maybe you can walk a little bit, but you get too tired or you're at a high risk of falling and you need too much help, maybe you're doing a little bit of walking, but also using a wheelchair as well. So the top right picture, that's a version of a tilt-in-space manual wheelchair. That's going to give a lot more support, but you're going to probably need some help to propel that chair. The left top one, that's a custom power wheelchair that would be made for you. We would figure out exactly what your needs are, and then you'd use a joystick or some other type of control to move that chair around your environment. The bottom is a lightweight wheelchair. Again, it would be custom made for you, and our patients would be most likely using their hands to propel that chair. So if we decide that we need a wheelchair, typically insurance will help to pay for it if we can justify that you need it and you qualify for it. So you'd be evaluated by your PT or an OT and an ATP, which is an assistive technology practitioner. And they would help us determine what kind of chair you need and what options would be available for your chair. And then we'd go through the process of getting insurance to approve it and ordering the chair for you. So that can take some time. Okay, so let's switch gears a little bit and talk about recovery and neuroplasticity. Okay, so when we're talking about recovery after brain injury, what does that really mean? So if we're talking about true recovery of walking, we mean that the way that you're walking after the injury is exactly the same as it was before the injury. You're not using a cane or a walker, you're not using an AFO. Your speed, your quality of movement is exactly the same as it was before your injury. So that would be a true full recovery. So our goal ultimately is to have all of our patients recover, but typically we're going to have to use some type of a compensation as well. So compensation is doing the task differently in any way than you were before your injury. So maybe you're using a walker, maybe you're using a cane or an AFO, maybe you're slower, maybe it just looks different than it was before. That would be some type of a compensation. So, you know, we wish our patients all could have a full recovery. but we ultimately want our patients to be able to go home. We want them to be functional in their environment, and we want them to be able to do all of the fun and important things that they want to do while they're still being safe and free from falling. So we're typically looking at kind of a combination of recovery and compensation. So we used to kind of think that after a brain injury, our brains were injured and they didn't change, and that's just kind of how it was, and we had to deal with it. But we're learning more and more about what we call neuroplasticity. So maybe you've heard this term, maybe you haven't, but let's talk about it. So what is it? The simple explanation for neuroplasticity is that your brain does change over time. Changes in our brain can be affected by our behavior, our environment, and then just the neural physiology. So after we have an injury to our brain may be able to create new pathways and relearn tasks if we provide the right type of stimulus. So I like to think about it like this. Imagine that you're living in a big city and you're driving to work. You always take the same route, and you know the route like the back of your hand. Okay, so one day something happens and your road to work is unexpectedly closed. You can't get through your normal route and you need to find a new way. You might need to backtrack. Maybe you get lost on a poorly marked side street or in a neighborhood you're unfamiliar with. Maybe you hit a dead end and you have to turn around again. The next day on your way to work, the road is still closed. So maybe you have to, or maybe you don't have to backtrack. The route's probably a little bit easier. And every day after that, the road around the blocked road gets more familiar and easier for you to get to work. So that closed road would be the damaged tissue after a brain injury. Your new route to work are the new neural pathways created by your changing brain and neuroplasticity. The more that we practice tasks following the principles of neuroplasticity, the more likely our brain is to relearn these tasks. So that's kind of how I think about it. We're not always able to open up that road that's closed. That would be like repairing the original neural pathways, but we're creating new routes in the brain, and that can lead us to the same destination. So for our brains to have optimal neuroplasticity after a brain injury, we found that there's 10 principles that lead us to our desired outcomes. We can use these principles in PT to help plan our treatments and reach our goals. So in 2008, there was an article published by Kleiman Jones that describes these 10 principles of neuroplasticity. If you're looking for some light reading, it is interesting. And the reference for this is at the end of my presentation. It isn't published in 2008, and in the world of PT, that's kind of a fairly new concept still. We're still learning the best ways to implement these concepts. But I do think that it's important for everybody on our brain injury team, the PTs, our patients, our families, that they understand these principles. Our patients can help us get insight into what's important to them, how to push them harder, and if they understand why we're asking them to do certain things during therapy and outside of therapy, I think it's just going to lead to better outcomes. So let's go through all of these principles with a little bit more detail. As we go through this, the quotes that I have on the slides are taken directly from that Kleiman Jones article. So if you want to learn more about those specifically, like I said, the reference is at the end of my presentation. So the first principle that we have is use it or lose it. If you aren't actively engaged in a task for an extended period of time, those neural circuits responsible for that task begin to degrade. So you've heard the term, oh, it's like riding a bike. Well, it might be like riding a bike, but if you haven't been on that bike for 20 years and you try to go for a bike ride, it's going to feel hard. It's going to be awkward. You might lose your balance and have to put your feet down, but eventually you are going to figure it out. It's going to get easier and you'll be able to reestablish those neural pathways. Okay. Number 2 is use it and improve it. So let's say you had a brain injury and you have been having trouble getting your foot to move. Well, let's say after a couple of weeks, it starts to move a little bit. Does that mean you can be done? Absolutely not. That means that you just have to keep working on it for it to get better. Once you start having function, we need to challenge that function if we want to see that continue to get better. Number 3 is specificity. This seems really simple, but it's also really important. So basically, if you want to get better at walking, then you need to practice walking. If you want to get better at riding that bike, then you need to practice riding that bike. We can't expect that doing something else, like just stepping in place, is actually going to make walking better. So practice what you want to get better at. Number 4 is repetition matters. If we want to induce neuroplasticity, we need to perform activity with high repetitions. There were a series of articles published around 2009, 2010, and what they were looking at is how many steps people take when they're in rehab recovering from an injury versus an average person going about their day. They found that in rehab, the average steps taken per day was somewhere between 200 and 800, whereas the average person would take somewhere between 2,000 and 6,000 steps per day. And even that 2,000 to 6,000 sounds a little bit low. So really it should be our goal of increasing repetitions to drive that neuroplasticity when we're in rehab. Obviously, we need to make sure that our patients are medically stable and can tolerate this before we push them too hard. Number 5 is intensity matters. I think this kind of goes along with repetition. When you're given a prescription for a medication, your physician is going to give you a dosage. He says, take 2 pills twice a day. When we're talking about therapy, we need to make sure that our dosage is appropriate as well. So how often are we seeing you? How long are our sessions? How hard are we working during those sessions? For optimal neuroplasticity, higher intensities are going to be more beneficial. So one thought here is that with high intensity training, we're increasing blood flow and oxygen perfusion in the brain, which is going to allow for improved neural growth and sprouting. Again, we need to be mindful of our patients' tolerance and monitor them to make sure that they're safe when we're pushing them during these intense sessions. Number 6 is time matters. After an injury, the brain wants to recover and it wants to heal. For some of that, we need rest. Once we're rested and medically stable, we want to start working towards recovery as soon as possible. The earlier that we can start rehab treatment, the better chance you have for recovery and optimal neuroplasticity. We want to recover as much as possible in that early window, in that more acute phase. That's when we're going to see the biggest gains. So I'm not saying that we shouldn't try to rehab. If it's been a long time since your injury, we should still. But we need to also understand that we're less likely to see those big major changes the farther out we get from that initial injury. Number 7 is salience matters. Salience means that the activity is meaningful for our patients. So I think in PT, it's kind of easy because our patients really want to work on walking. And that's one of the big things that we're going to work on, and that's going to be meaningful for them. But let's say we have a younger, maybe a teenager who has a concussion. Maybe they're a soccer player. If we ask them to do things that are involving, a basketball and shooting basketballs, they're probably not going to care about those tasks as much as they would if we were asking them to kick a soccer ball or do some soccer drills. If they're more engaged in the session, they're going to want to try harder, they're more invested, and that's going to help to drive neuroplasticity. Number 8 is age matters. Younger brains are just in general more plastic and adaptive to change than older brains. So it's more likely that younger people are going to show a greater degree of recovery following a brain injury. Again, does that mean if we have older people with brain injuries, we're going to just give up on them? Absolutely not. We're going to just know that it might take longer, it might be a little bit more challenging, and they might not make as full of a recovery as they would if it were a younger person. Number 9 is transference or generalization. So earlier I said specificity matters, and if you want to improve walking, you should work on walking. This principle says that even if we work on walking, other tasks that are similar might show some improvement as well. So let's say we have somebody who is impaired with standing balance. We're working a lot on challenging walking tasks, and what we'll probably see is that their standing balance does improve some as well, because those activities are related in some sense. And the last principle is called interference. So this is when one training experience can impede acquisition of similar behaviors. So let's say you have a type of a brain injury and we're learning to walk and we're using a walker. Your brain is learning to walk with a walker. If we ask you to take that walker away, you're going to have to relearn how to walk again. So that use of walker might interfere with learning to walk without the walker. It's still going to help get you on your feet and get you moving, which is ultimately our goal. It just might be a little bit more challenging to get rid of that walker because you're essentially having to unlearn how to use a walker and then relearn how to walk without it. And so that can just interfere with what we're doing a little bit. But again, ultimately our goal is to get you up and moving. So we got to do what we got to do. Okay, so conclusion to my talk today. PTs are awesome. They can help you with your mobility. And they're an important part of our brain injury team. Our ultimate goal in physical therapy is to improve your mobility and get you back to your life. We have a lot of different tools and strategies to help you reach your goals. And then the concept of neuroplasticity is exciting. It's fairly new, and it's useful for understanding how our brains recover after an injury. We can work together to improve your quality of life and your mobility and get you back to where you were as best we can. If you have any questions for me, you can contact Rebecca or Carly at North Dakota Brain Injury Network, and they can get a hold of me. Otherwise, I just want to thank you for listening to me and hope that if you have any mobility needs that we can work together.